Okay, everybody, people can take their seats for this afternoon's first session. So hope you all enjoyed your lunch and the very sticky cakes that come with it. We're now going to focus on, we've got four speakers with 3 presentations in this session, and we're going to focus on the environmental aspects around virus transmission. So without further ado, we're going to do as we did before. We're going to have the questions at the end, so all 3 speakers will talk and then we'll do questions. Without further ado, I'm going to introduce our first speaker, who's Chris Keane from HSC's Science Division. She's an occupational hygienist, and she's going to talk about some of the environmental assessments.
Thank you very much, Cath. Can people hear me? Yeah, people can hear me. So yes, thanks for coming. Thanks for coming back quickly from London. I'm going to talk for about 10 minutes about one small part of the Protect programme, something we've done in theme 1. We've called it the COVID out study. Okay. You're going to hear a slightly different perspective from me this afternoon after all the fantastic sort of talks this morning. I'm an occupational hygienist. I did wonder quite early on in the pandemic, you know, when it all started to become very, very serious, if there was any role at all for occupational hygienists in solving this problem. But I'm in no doubt now, having spent the last 18 months working on COVID-related work, that we are a small, tiny part of the solution. Because what we do and what we've always done is protect people from harmful exposures in the workplace. And essentially that is what we're trying to achieve here, to prevent transmission. So I'll not read the slide. Everyone in the room knows what this slide's saying. All workplace outbreaks are investigated, but generally that investigation is conducted to control and curtail that outbreak and move on. They're not there to collect systematic research data from every outbreak. The IMTs, the OCTs just don't have the time and the resource to do that. So what we set out to achieve with this study it was very challenging, and you'll see some of the challenges in the next few slides, was to study live outbreaks in workplaces, only in workplaces, and to collect a pretty comprehensive set of data from the outbreaks. And again, I'm not going to go into this slide in detail because there's a lot of detail on it. Suffice to say, we're trying to collect a very comprehensive set of data from a workplace outbreak at an individual, at an environmental workplace, and at a population level. And I've got some references in this, the data framework for this. We have published it. So if you're interested in diving into it in great detail, there's a reference slide at the end, so you can actually access our data framework and the tools that we've used to collect data. They're all available online for other people to use. Just to be clear about this, I don't think I made this clear earlier. This is a voluntary study. Obviously, we can't insist that we're going to these workplaces. And we have to remember that these employers are under a lot of pressure. They're under a lot of pressure anyway through, you know, all the other factors around the pandemic. And then they've actually had an outbreak in their workplace. So a lot of these companies were under a lot of pressure. And for us to go along to them and propose a voluntary study where we come into the workplace, and whilst we're doing our best to minimise the disruption on their operations, we can't say that they won't know we're not there, but we will have some impact. So it's been a bit of an uphill battle, and it's been a great learning curve for us in actually selling this study to employers. You know, we're a long way from getting 100% recruitment rate. I think we've had something like 20% or less than 20% take-up rate. So for every 5 workplaces that we're notified of an outbreak and we contact, if one of them agrees to have us on site, we'd see that as a pretty good week, really. We'd see that as quite a successful week. And another one of our aims, which we've struggled to achieve, originally we intended, or we hoped, to get on site really early on in the outbreak and study the outbreak as it developed, as it unfolded. As I said, these are voluntary studies. By the time we've contacted the workplace and the workplace have thought whether or not they've got the time and inclination to engage with us, it's often 1 to 2 weeks after the outbreak's been declared before we actually get on site. So we have to live with that. We don't live in a perfect world, and workplace studies are hard to conduct, but hopefully you'll see the value of some of the data that we've collected. Just to sort of point out a few details here. So we're focusing purely on workplace environments here, and we're focusing on, in order to make it as, not simple, but simpler than it would be otherwise, we're focusing on workplaces in certain sectors. So we've looked at manufacturing, we've tried to look at food production, manufacturing, office environments, warehousing and distribution. We've not looked at workplaces where there's a high degree of public interaction with the workforce. So we've not gone into retail premises, hospitality premises. They would be much more complicated to study. I mean, this was hard enough as it was. And we've not looked at healthcare. Again, there's other studies, plenty of other research going on in these other sectors. So that's the reason why we've focused on the sectors that we have. We had a very strong focus early on the food and drinks sector. I'd have to say that the uptake within that sector was incredibly low. That sector in particular were under a lot of pressure and continue to be under a lot of pressure from the pandemic and from labour shortages and from various other things as well. And I think getting them to engage with this voluntary research on their sites was maybe a step too far for that industry. So we've tried quite hard to recruit from the food and drink industry. We've only managed so far to successfully recruit one food production site, but they've helped in, so a lot of you will know in here, they've helped in other ways with various other themes, various other parts of the tech study. So they are willing to engage with research. I think this one was particularly problematic for them. I'm going to give you some very, very early insights, and these are very early insights. We've collected a lot of data so far, and the data analysis is at a very early stage. So some of these might seem a bit simplistic, but hopefully they'll chime with what people recognise from other parts of Protect. So this is some information from the first site that we recruited, okay? It was a manufacturing premises, an outbreak in March to April of this year. The graph's not great, but you've got a very different attack rates in different areas of workplace. I think there are 9 different work areas on there. The attack rate varies from none at all in the warehouse area to 30% in some of the production areas. In this particular case, just one site, so there was a pretty strong correlation between the population density in the work areas and the attack rate. So as you might expect to see. Interestingly, quite a high attack rate in the offices. And while we were on site, we noticed there was quite a lot of interaction between office staff and the shop floor. The office staff weren't constricted to the offices. They were out and about, they were moving around the workplace. And maybe that's what's driven transmission in that particular group. Another one, and this is even more recent, we only recruited this site 3 months ago. This is an office environment, quite unusually for us, quite a high degree of public facing activity at this site, and an attack rate of almost 50%, which I think is very high. I mean, I'm not an epidemiologist, but that seems like a high number to me. I think what we suspect has happened here is that you've got security staff moving around the workplace. We did some surface sampling in the security staff office, and it was one of the places where we did identify surface contamination. We've not identified it in many places. That's not to say that there was a transmission risk from that surface contamination, but there was certainly something going on in that office. And then we've got 4 or 5 security officers that were moving out of that office and moving around the work site. So possibly they have driven transmission in that situation. As I said, these are very early insights, and some of them are not. Social distancing does not stick in the manufacturing environment. It's difficult to rearrange complex production areas. If you've got large fixed pieces of equipment, you can't just move out the chairs like we have in this room. Noise, the combination of noise and face coverings make it very difficult to communicate. You'll often see people leaning in to have conversations. And I think we have to remember, I mean, Marty did some sort of questions and answers earlier. You know, a lot of us have been working from home from doing it. These people never got that. It's always been their normal to be going into work. So I think that over time, they've just got fatigued with a lot of the controls and social distancing, unless someone's constantly reminding them, is something that they often forget to stick with. Ventilation, we've heard a lot about. It's been the biggest challenge, I think, for industry to get their head around. It's been the one that's most difficult for them to understand. We identified quite early on, a lot of the guidance that was out there was just way too complicated for most duty holders. It was unusable for them. So there's been a lot of work to develop some simple ventilation guidance. This is just one tool, British Occupational Hygiene Society ventilation tool. This ought to be accessible and usable to most duty holders out there that are trying to manage a workplace. It won't answer every question, and it won't deal with complicated situations. You need a specialist for that. But it's a really simple to use tool that anybody ought to be able to get some value from. And just an observation that I've made, and we've been to 10 sites so far. None of them had done anything to reconfigure their mechanical ventilation systems. They didn't really understand what their mechanical ventilation systems were doing. any enhanced ventilation at any of these sites has been achieved through opening windows, opening doors. Sorry, I'm going to run out of time. Very quick, I think. There's also been a lot of talk about surface sampling. This is not my slide. This has come from Barry Atkinson at the UK HSA. So Barry's been part of this study too. We can detect very low levels of RNA on surfaces in these workplaces, but I have to stress they are very, very low levels. We can't detect viable virus on these surfaces, and I'm informed by Barry that this kind of level of contamination wouldn't be expected to represent a transmission risk. So very quickly to summarise, it's been a hard study. Recruitment's been very challenging, environmental assessment's been very challenging, buildings are difficult places to evaluate in a 3 or 4 hour site visit. But I would say that the real world insights that we've generated from this study, they've added quite a lot of detail and colour to some of the epidemiology studies. We've supported the validation of some of the models that the people in Theme 2 have been working on, generated some audience appropriate guidance aimed, in the right kind of language for duty holders to understand. And we're all kind of finding, or we're all pointing in a similar direction. So if we all triangulate the findings from different parts of the site, then I think that gives us confidence that we're moving in the right direction. Just to thank the collaborators, this has been a multi-agency study. So, I'm fronting it up, but there's been probably 20 or 30 people working on this study. There's some references on that slide there. We've published our data framework and all the rest of it. If people are interested, you can go online and you can find them there. And I think that's all I've got to say. Thank you very much for listening.
Many thanks, Chris, for really good insight into the COVID out study. I'm going to hand straight up to Simon Coldrick. Simon's a senior scientist who works in the Computational Fluid Dynamics team at HSE, and he's going to talk around the modelling the physics of transmission.
Thank you very much for the introduction there. So yeah, I'll talk about that. My name's on the first slide, but sort of to quickly move on, we've seen the diagram on the right before. This is just to show how our work fits in the grand scheme of things. We're looking at the droplet models which interact with QMRA models that Simon Parker's demonstrating, for example, at the back there, and other transmission models like that of Nick Warren's. So this is a collaborative effort. It's myself, Adrian Kelsey, Matt Ivings and Rory Hetherington at HSE. DSTL, we've got Tim Fotes, Simon Parker, Susie Abbs, Ben Higgins and Tom Maishman, and of course Cath Noakes at the University of Leeds. So everything I'm going to present is a result of this collaboration. Very briefly, what I'll talk about is what we sort of set out to do. That's sort of changed to some degree as we've gone along. I'll talk about CFD modelling of exhalations, some applications of the model, some examples, and some conclusions that we can draw. So the original aim was to try and understand and characterise respiratory droplet dispersal using a modelling approach. Some example research questions. I don't think we can answer them all in this presentation, but things like what are the important fluid dynamics processes that affect the dispersion of droplets? How effective are screens, for example, in reducing the effects of transmission? What effects do ambient temperature and humidity have on the dispersion of droplets? And what effects are things like social distancing have, or how can we look at those things? So the approach was to develop a CFD model that accounts for things like the key physics and the ventilation, and then to try and model the behaviour of the emitted particles as they evaporate and float around the space. So if anyone's not familiar with computational fluid dynamics, I'm sure a number of people in this room are and are practitioners in it. It's a sort of widely used industrial and academic technique for looking at fluid flow in spaces. What you normally have is a geometry of an internal space of some kind, and in that space you're solving the basic fluid flow equations. So in this case we've got a room which has got ventilation flows, and we've got a person in it who's exhaling, so that might be talking or speaking, sorry, coughing. And then what we do in this approach is to model the exhaled particles. We track particles that are injected sort of concurrently with the breath flow. They can interact with the room air, they can evaporate, they've got a distribution of diameters, and thanks to sort of Jonathan Reed, we've got an artificial saliva model as well, which controls the evaporation rate. So the images on the right, one's just to show the diameter distribution that in this case we use this BLO model, and the images is taken from the literature of someone coughing, and so just to show that we've looked in the literature and taken data from the literature to inform our model. So this kind of modelling approach has got some advantages and limitations. What's good is that we can look at relatively complex geometries. We can look at things like ventilation and ambient flows. We can look at the distribution of particle sizes and how they evaporate. We can estimate how things or the quantities that deposit on surfaces and stay in the air. We could potentially look at an assessment of viral load in those droplets. And I think a good sort of bonus is that you get a visualization to help understanding of the fluid flow processes. This is bearing in mind the limitations. So we're modeling an idealization, not reality. So we need to strip away complicated things till we can actually model it. We are limited by the strength of the input assumptions, and we know that models need to be compared against data to have confidence in them. The models runtimes can be quite long if you're looking at this kind of complex modeling. There's many inputs, so we're sort of more comfortable with making comparative rather than sort of absolute results. So I talked a bit about model validation. So we can look at simple things like the evaporation of single droplets. We could look at the jet that's exhaled, and does that correspond to an expected result? We're also fortunate to sort of be party from data from, I could say Public Health England, sorry, Alan Bennett and co-workers who did some nice experiments early on last year where they were looking at the efficacy of masks, and they've got somebody in a room who's undertaking various activities. I think we heard about this a bit this morning, where they were coughing, talking, singing, and so on. And what they were doing is coughing, talking, and singing in front of some sample plates in a room. And what we can do in the model is model this. We can put the person in the room with some pretend sample plates and some air samplers, and then count how many particles end up on those sample locations. And we did that, and it was quite surprising, really. But the model performed, I think, surprisingly well, and it gave us quite a bit of confidence to use it going forwards. So I'll just give some examples, some of the questions we were answered. So this is talking about the effects of things like temperature and humidity on dispersion. So what we can look at is how the ambient conditions affect the evaporation and transport of droplets. In this case, we've got a meeting room with a person in it. You can see the ventilation flows coming from the ceiling. And it's possible to look at different temperatures, different humidities, and then make some assessment of how the exposure changes with that. So this isn't looking at biology, this is just looking at sort of physics and engineering and how that affects the droplet dispersion. We also were asked questions about screens, and I think that's an application area of this model, which is quite a nice one, because we could look at the different screen geometries. So we've got a room with some basic ventilation and a person stood in front of the screen. And what we could do is look at zones in front of and behind the screen, and look at how the exposure changes under different ventilation conditions and for different sort of screen configurations. I mean, in this case, it was the presence or absence of the screen. And we could look at different activities. So we could look at speaking, coughing. And we saw that, in some cases, the screen helped prevent the movement of droplets when you cough at it. But if you're speaking, then ventilation flows can still carry these very small particles into the space behind the screen and result in an exposure. I've just got a couple of animations of this. It's quite a sort of nice visualization to show it. So on the left, I've got the no screen case. The person talks for about 25 seconds. And you can just see the particles begin to be ventilated out of the space. So this is actually 10 times the amount of particles that you would exhale if you were talking, but it just gives you an indication of what goes on. So this is showing about 5 minutes. And then if we look at the next one, again, talking at the screen, you can see the particles, some of them are falling on the floor, some of them are impacting the screen, and some of them drift into the space behind the screen. And then some of them are ventilated out. Another sort of application that we're looking at a bit more recently, I sort of won't go into this is still very much work in progress, but we are looking at things like carbon dioxide. So the room here is full of monitors monitoring carbon dioxide, and it's what kind of a proxy is that for particles, and especially those particles that have a different sort of size range. So just looking at the images on the right, showing what we've got with particles versus CO2, we can put a filter in the room and then remove particles, but not remove CO2, and make some conclusions about that. So this is work that's ongoing really at the moment. So my final slide, just to sum up really, we've developed a model of exhalations. That model performed quite well, surprisingly well against the test data. It's helped provide insight into the sort of dispersion and the dispersive characteristics and the physics of droplets. We've used it to model a number of scenarios, and that work is sort of ongoing at the moment. I think the final 2 points really are sort of ones that are more to do with the Protect project, in that we've been able to develop expertise and also tap into other people's expertise and benefit from collaboration with people that sort of know about these different aspects of the physics. So that's all from me. Thank you very much.
Thank you very much, Simon, for that. So our final presentation for this session is a double act. Sarah Beale from UCL and Sarah Rhodes from the University of Manchester. We're going to talk about some of the work from, I think, Team 3 on the occupational risk of COVID transmission.
Hi everyone, I'm Sarah Beale, and I'm from the UCL Institute of Epidemiology and Healthcare, and together with my colleague Sarah Rhodes from the University of Manchester, we'll be taking you through a whistle-stop tour of some of the work in Theme 3 on occupational risk of COVID-19 transmission. So the work that I'll be presenting today is drawn from VirusWatch, which is a large prospective cohort study of about 50,000 individuals across England and Wales that looks, amongst other things, at risk factors for SARS-CoV-2 infection. So the first study was focused on how occupations differ in their risk of SARS-CoV-2 infection beyond the effects of non-work variables that are likely to influence this relationship. So those include sociodemographic factors, notably things like age and deprivation, as well as health-related factors that are not due to occupation necessarily, and non-workplace activities, including public transport usage and socialization. The second study built on this and used electronic contact diaries that were conducted throughout different important phases of the pandemic to investigate how work-related contact patterns differed by occupation and over time. So results from our first study around infection risk found that there were substantial differences even after adjusting for a range of non-work factors between occupations, in terms of their risk of either serologically or virologically confirmed SARS-CoV-2 infection. So these graphs present risks compared to other professional and associate occupations, which are broadly what we would conceptualize pre-pandemic as kind of office-based professional occupations. So we found a particularly large increased risk within healthcare professionals, where after adjustment for non-work factors, occupation appeared to contribute approximately 42% of the infection risk within this group. There were also substantial differences in terms of elevated risk for teaching, education and childcare workers and people within indoor trades and process and plant occupations. And social care and community protective services. We found some evidence as well in leisure and personal service occupations and sales and customer service that this was less pronounced. For all of these groups, with the exception of teaching, we found that this risk was elevated within the first and second wave of the pandemic, but was attenuated by the third ongoing wave, except in teaching, education and childcare workers for whom the risk remained elevated. Where possible, we also looked at specific frontline occupations, and we found substantial differences across these occupations as well. In particular, you can see healthcare workers, so nurses and doctors, teachers within primary and secondary schools, but not within higher education, and people in warehouse and manufacturing occupations and within food preparation and hospitality had elevated risk, as did carers. Again, we found that for some occupations that increased risk, after adjusting for non-work factors, occupation contributed a large amount of infection risk. And in the three kind of most pronounced groups, which were carers, primary school teachers and nurses, we found occupation appeared to account for approximately half the risk of SARS-CoV-2 infection across the entire pandemic so far. So these differences in infection risk were also qualified by differences in contact patterns over time between occupations. So this graph shows the interaction between your likelihood of attending work across time by occupation. So as you can see, some groups, particularly trades occupations, had persistently high probability of attending work. And others, so professional occupations and managerial and administrative ones, had persistently low probabilities and tended to work from home. Regarding other groups, we found that there was variation according to workplace openings and closures, some of which were due to pandemic restrictions, others, like if you can observe in teaching, were due to non-pandemic restrictions, so that is summer closures. Amongst people who did attend the workplace in person, we also found some persistent differences. So teaching, sales, and healthcare professionals tended to be exposed to higher numbers of people within the workplace, just in terms of space sharing, and to a less pronounced degree in terms of close contacts at work. And that in general, this space sharing tended to occur over a long period of several hours. We also found fairly pronounced differences in terms of face coverings. There's a gradient, as you can see. So healthcare and transport professionals tended to be quite likely to wear a face covering during close contact at work across all time periods, whereas teaching, other professional and associate and outdoor trade occupations had much lower probabilities of wearing a mask during contact. We also found notably that after May 2021, there was a substantial decrease across all occupations in their likelihood of wearing a face covering during contact at work, but these professional differences still held. In terms of bringing this all together, we found that there were persistent differences in infection risk across occupational groups. And it appears that high-risk groups that we identified in study 1 tended to be those that demonstrated multiple elements of contact-related risk within our second study. For example, teachers tending to have fairly high levels of workplace attendance, being exposed both kind of within the space and at close range to lots more contacts over a long period, and being less likely to wear a mask during contact. This has the potential to inform interventions, and that can differ appropriately by sector depending on differences. However, there are, of course, generalizability questions in that this is a single prospective cohort study and sample size was limited for some groups, particularly some trade occupations, and that adjustment for non-workplace factors is always a challenge. Next steps include linking directly our contact-related factors with infection risk, and also understanding worker-related vulnerability, so differences in vaccination uptake and in health status by occupation. And I'll hand over to my colleague, Sarah Rhodes.
Thanks, Sarah. So I want to start by talking to you about some work commissioned on the ONS Infection Survey, which is another longitudinal study. This one includes about 300,000 adults of working age and about 3 million sort of data points. The key thing about this particular epidemiological data set is that everybody is getting tested constantly by the ONS throughout the survey. They're getting PCR tests at least once a month and more frequently in the beginning. So this means that this particular data set, you kind of minimize bias that's due to sort of differential testing by occupation. Clearly, some occupations are more likely to either have had access to tests early in the pandemic or to be using lateral flow tests now because they're expected to by their job. So the kind of approach that we're using is kind of looking at the time to the first positive test within the infection survey. So that might be missing infections that have happened before or between visits from the ONS, but using occupational information classified using 4-digit SOC codes. I've then kind of repeated that using different time tranches and actually done a slightly different multi-level analysis where you kind of allow for multiple infections per person. and adjusting for a series of different confounding factors. So this is a really brief taster of what we've been doing, but striking things here when you compare the risk. And so what's happening here is hazard ratios comparing a set of different workers who are considered to be essential workers or key workers, and comparing them to people who were non-essential workers who would have mostly been at home through the majority of the pandemic. And I guess just a couple of things that stand out from that. One is the healthcare sector. You'll see that healthcare professionals seem to have sort of less risk than the other non-essential workers, whereas healthcare health associates and support staff have a more elevated risk. And possible reasons for that could have been to do with earlier access to vaccines. Vaccines aren't taken into account by this particular analysis. Could be to do with access to PPE, potentially, or it could be to do with getting infected much earlier in the pandemic before the infection survey started. Another key result to see there is food production, and this has been seen consistently in several studies, that food production work is not coming up as having an elevated risk, even though consistently there's been lots and lots of outbreaks in the food production sector. So we need to unpack that a little bit more, I think. There's a few potential reasons for that, possibly to do with people who are kind of temporary workers, aren't necessarily identified as food production on the infection survey and other things. So I saw some quite similar results to what Sarah saw with Virus Watch. We saw increased risk for people working in social care, education and food distribution and sort of food hospitality. We did another study to do with mortality using the ONS mortality data and saw similar things, mostly saw the same sort of results, but education came out in the infection survey, as did sort of police and protective services, where we didn't see them in our mortality paper. Adjustments for confounders didn't seem to make much difference, whereas when we were looking at mortality, it made a dramatic difference, like 4-fold risks were becoming sort of 1.5-fold once we'd taken demographics into account. And it's quite clear, I'm not showing it here, but relative effects are changing over time at different points of the pandemic. So this links to other work that we're doing in theme 3. I'm doing a systematic, several of us are doing a systematic review where we're trying to combine evidence from multiple different data sets, because we know that different data sets have got different inherent biases. We've got a project that some of you come and visited us at the back to play with sticky notes and looking at directed acyclic graphs, but there's a reason for that. It's because we are really thinking very carefully about what question we're asking and what we should be adjusting for, what we should be taking into account. So for example, if you want to think about this sort of long-term effect on occupation on your COVID risk, then your long-term effect, you might want to include socioeconomic status, housing, things like that, or you might want to think about the sort of shorter term. And so whether you adjust for socioeconomic status or long-term health conditions is a bit of a sort of, there's disagreement in that area. So we're trying to think about that very carefully. And that's a project that you can see by that link. I'm doing a lot more with the infection survey, trying to look at the time more carefully. And also we've got a job exposure matrix to try and capture for each job title what exposures on average they're likely to have. So for example, how likely are they to be coming into contact with lots of people during the day? And we've got other data sets that we're working on to try and triangulate results. So we've got different analyses using the mortality data. We are working with Biobank, and we've also working with the National Core Study on Longitudinal Linkage of Collaboration. So thank you very much. Thank you to all our collaborators, both within Protect and within Virus Watch. There was funding for, obviously from Protect, there's also Virus Watch is funded by the MRC and NAHR. Thank you very much.
Thank you very much, Sarah and Sarah. So we have a few minutes now for questions. So does anyone in the room have any questions that they would like to ask of any of our presenters today, or indeed online? I can see there's quite a number of comments online about the relative use of face coverings in different settings and the different awareness of hygiene in different settings. More comments than questions. Can I ask, Sarah, the Virus Watch data, it was really striking how, particularly for healthcare workers, how the risk really dropped in wave 3, even though they're still obviously front line. Did you explore why that was? Do you think it's vaccination that might be that risk?
So it's really difficult, I think, to disaggregate specific mechanisms, but we can definitely make some suggestions, which a key one is PPE. So differences, particularly from wave 1. So we had to collapse wave 1 and 2 within our analyses because of serology. It was not necessarily possible to assign a particular wave to people's infections. But after the first wave of the pandemic, kind of access to PPE was much greater. Also, if a large number of people become infected earlier, then immunity itself became another factor that likely accounted for that really substantial change within healthcare workers.
And there's a question here for Simon on the that's come through on the chat about, I think it might have been prompted by Wendy's thing this morning about whether CFD models are affected by whether virus is being emitted from the mouth or the nose.
Yeah, that's an interesting question. I think it's one that we discussed a little bit at lunchtime as well. Yeah, certainly the model is based on stuff coming out of the mouth because we're looking at activities like oral activities, and the particle size distribution is based on measurements of that. It is possible with that model to look at what is produced by the nose. Again, we discussed the possibility of doing that in the model. I think it comes down to whether there's evidence that there's virus contained in the or sort of from a nasal source or from an oral source, and I think that's sort of something that we're still unsure about. I guess, have you got any other comments on that, Cath?
Yeah. Oh, question back there.
Hello?
Hi, we can hear you.
Sorry, Cath. Yeah, I wanted to ask a question about the virus watch data. Specifically, I'm assuming that there is some evidence that the occupations that show up as having lower likelihood of infection over all of the waves. Have you been able to account for the likelihood that they were infected before we had a good testing process in place? Because some of the things like food production that we would expect had to keep going through the beginning when we weren't recording.
So, the way that our data is collected, I think we didn't really have time within the 10 minutes to go into detail, but in theory, it should account for that where possible, because as well as tests within the study itself and reporting from participants, we also have linkage to SGSS, so we should get where available NHS results on people. Now, of course, that is very much skewed towards certain occupations. However, the serology results, again, it can't be specifically attributed to the first versus the second wave, but would pick up some infections within other occupations that would have been infected earlier in the pandemic, but not necessarily symptomatic or not necessarily prioritized for testing at that early phase. So hopefully, while there is, of course, some issues with bias introduced by these different sources being combined, it should account for quite a lot of that early risk as well as the later risk. So those the kind of high-level statistics that I was showing at the top of those graphs, those are the ones from the overall trends. And apart from teachers, generally the differences in infection risk were observed earlier on.
Thanks, Sarah. I've got a question online for Chris. It's quite a brief question.
Okay.
But could you clarify where you talk about environmental data, clarify what the value of CT value of less than 32 means? Is that highlighting a risk?
I can try, but it's not really my area of expertise. But I think basically the lower the CT value, the more RNA is present in the sample. Our colleagues at UK HSA kind of classify the results into very low, medium, high. I think anything below 35 they would consider to be low to medium. I think the kind of CT values where people get excited that they might be enough there to be worried about are much lower than 32. I don't, but I think probably the UK HSA people are better to give a detailed answer on that.
I think that was the lowest value found in any of
I think that represents very low contamination. We can find it, but then PCR is very sensitive.
Great, thank you. I've got one more question online and then we'll go to the one in the room. So for Sarah and Sarah again, did the occupational risk studies take into account the impact of lockdown? So the fact that certain businesses actually were just closed for large periods of time and therefore their risk might appear different because of that?
Yeah, I guess that's why we're starting to look at it over time and looking at sort of time tranches. It's not an exact thing of being able to fix and match exactly how the differences relate to the mitigation factors that are in place, including lockdown. But I've been looking at it, I've kind of divided the data up in terms of periods of lockdown and not. And there's definitely differences during lockdown compared. So teachers, for example, did not seem to have an elevated risk in the early phase when all the schools were closed. But then once schools were open up again, then that's when the elevated risk began. So we're doing a lot more of that, trying to unpick it more carefully.
Do you think you might underestimate things like hospitality? Because a lot of that was closed.
Yes, definitely. So we just got to look at hospitality and the periods that hospitality was open to really understand that.
I think there was I can see a hand at the back. Can't hear you very well. Mike?
Can you hear me now?
Yeah.
Yeah. Sorry. The one of the notorious issues when doing the kinds of analysis that you've described is getting good quality data on occupation. So can you tell us a little bit about how you went about making sure that you had the best available information about an individual's occupation in the analysis that you did? Thank you.
I can start with the virus watch data. So we have two fields. So this was collected when people enroll within the virus watch study. So it's not linked from another source. And what we do is we ask people first to write kind of a one word or, a very brief description of what their occupation is, and then provide some more written detail if they think that'd be useful. We entered both of these fields into a software that is assigning SOC codes, which are how the UK classifies occupation. And we used semi-automatic processing, which is a kind of recommended way of doing that, which is a score is assigned in terms of certainty, and below a certain certainty cutoff, you get trained researchers to validate each score. So you kind of go through the dodgy ones. And this has now, of course, it's not perfect. And as you said, occupation is difficult to allocate, but this at least has the benefit of being a recent measure of occupation, which sometimes can be challenging to get, particularly for the early phase of the pandemic. And it is kind of an established method of assigning occupational groups.
Yeah, so I think the ONS has done something very similar. People enter their occupation sort of in free text, and then they've used automatic coding to turn it into a 4-digit SOC code and also industry codes where possible. I think the challenging thing for us is trying to then take those SOC codes to turn it into meaningful groupings. So one of those groupings there is I'm doing kind of repeating a previous study, and then I've also repeated using a different study, trying to use their grouping. So you've got those, there's obviously many 4-digit SOC codes, and those groups are far too small to do anything meaningful with. So we need to then regroup them into occupational groups, and that's where different studies are using different groupings, and you get inconsistent answers, I think. So it's challenging, and we're trying to look at that.
Great, thank you very much. I think we are out of time for this session. So can I thank all of our speakers again in the usual way, and then there's some more tea and coffee. So thank you very much.